We have Dr. Westphal, President and Medical Director, Beacon Health Options. He is no new presenter for us. We are always grateful to have him come back for his presentations at least 4 times a year. So welcome back, Dr. Westphal, and I will stop screen sharing so that you can take over and take it away. Guys, please feel free to put any questions in the chat and we will bring them up to Dr. Westphal as needed. Mahalo.
Thank you. We're going to get started. So I was interested in if people are doing anything different to sleep since COVID, because insomnia was a public health concern before COVID, and at least all the data shows that it's gotten worse. Oops. All right. Gotta figure out how to.
I think you can just click anywhere on your presentation and it'll go, or the right arrow on your keyboard.
It's not working. All right, let me try something else. There we go. Okay.
There you go. Oh.
So what we're going to do is we're going to talk today. My objectives are to talk about the mental health risks of chronic insomnia, and what's the recommended first-line treatment, the limitations of pharmacological interventions, and the limited role of sleep hygiene. So we're going to cover, and a lot of the things that people are doing would be included in sleep hygiene. So that was interesting. This is a no-brainer. Good sleep is necessary for good physical and mental health. It's been insufficient sleep has been a pervasive and prominent problem. There's a lot of evidence that poor sleep increases the risks of lots of medical and mental health dysfunctions. And it was considered to be a public health epidemic even before COVID. So this paper was done in 2018. So it was a problem, and Mina identified one of the major issues. It's the increased usage of smartphones and electronics, and the idea of reading a paper book before you go to bed is a good sleep hygiene. So there's the increased use of electronics was associated with poor sleep before COVID. And a recent review from last year took a look across the world at people that report poor sleep or insomnia. And this is a no-brainer too. About 40% of people from the general and healthcare populations reported significant problems with sleep and insomnia during the height of the epidemic. So in general, and what's interesting is healthcare workers and the general population really had no significant differences in terms of reporting sleep problems. So I'm going to focus today on insomnia, which is a specific sleep problem, and especially chronic insomnia. There's different ways of characterizing insomnia, whether you have some problem sleeping, whether you have insomnia problems with daytime consequences, meaning that you're sleepy or poorly functioning during the day, the idea of sleep dissatisfaction, and then the idea of an insomnia diagnosis. So an insomnia diagnosis is more stringent than any of these, any of the other ones. So sleep problems are relatively common. About 1/3 of the general population before COVID reported at least one insomnia symptom. And the key issue for sleep complaints is whether there's daytime consequences. So if you don't have daytime consequences, you really you don't fit the diagnostic criteria for insomnia, and so that prevalence is between 9 and 15%. Again, pre-COVID. So is a significant problem, higher in women than men. And the symptoms generally increase with age, but the diagnosis and the rates of people that are dissatisfied with sleep tend to remain relatively constant. Many people have transient disturbances in sleep that last a day or two, or maybe a week or two. That has not been reported to have health consequences. But when insomnia becomes chronic, it has a significant health consequence. So, and we don't really have a lot of epidemiology on this, but in a large United Kingdom study, about 3/4 of people that reported insomnia symptoms, it lasted about a year. And about half of, in another study, about half of the people that reported insomnia still had it at 3 years. So it can be chronic, and the health consequences I'm going to talk about are the result of chronic insomnia, not the transient insomnia that we all experience every once in a while. So there's significant morbidity in terms of healthcare utilization, work absenteeism, reduced productivity, the risk of accidents, and it's also related to a number of physical illnesses. And the most studies have been done on type 2 diabetes, that it seems to be very much associated with people that sleep poorly and have sleep disorders. And we don't understand yet what the causal mechanism of that is, but it's fairly clear that sleep and weight gain are highly related. And there's actually been some interventional studies with people who are overweight that just intervene on having them sleep longer, and they lost weight. So there's a very significant but unexplored relationship between sleep and weight. There's also people who sleep short duration, that's usually less than 6 hours, have been associated with obesity. And as I said, there's a potential causal relationship between greater rates of weight gain and sleep. In general, insomnia causes decreased quality of life and decreased functioning in many areas. And I'm going to focus today on the increased risk of behavioral health disorders, so depression and anxiety. So insomnia and mental health, the symptom of insomnia is a common feature of many psychiatric disorders. Almost all of the mood and anxiety disorders can have insomnia as a key feature. It can also be comorbid, meaning it's an independent disorder along with a mental health disorder. And depression and anxiety, the most common comorbid psychiatric disorders among people that report chronic difficulties sleeping. It's also important that in people who get psychiatric treatment, if their insomnia persists after mood symptoms have remitted, that makes them at an increased risk for having a relapse. So, and there's a very significant relationship between poor sleep and insomnia, chronic insomnia, and depression. So the severity of the depression and how fast it occurs as a relapse is related to if a person has a sleep problem. And in many cases, and this is the state of the knowledge in 2007, insomnia precedes the psychiatric disorder. I'm going to review some more evidence, more contemporary evidence that actually gives insomnia a much more key and causal relationship to psychiatric disorders, especially depression. So as you can see, and this is again information from approximately 15 years ago, insomnia often precedes mental health disorders, especially mood disorders. And more recent knowledge is, and this is the best study of mental health disorders after a disaster event, and those of you who attended these before have seen this slide. So there was a 2016 wildfire in Alberta, Canada, that left almost 90,000 people without homes. And a very good study looked at the prevalence of mental health responses. The most prevalent response was not PTSD or depression, it was insomnia. And almost a third of the people developed insomnia after this disaster. So interpersonal stress has been a key factor in terms of how people sleep, and that's evidence in the responses to the icebreaker, the stress of moving to the mainland, and praying a little more, meditating a little more, all ways of damping down on the stress we feel. So people with insomnia tend to report higher levels of interpersonal problems and more distress. And that's going to be tied to a relatively new concept. The idea that, and this is the physiological basis of chronic insomnia, and again, that's people who have significant problems sleeping over at least a 2-month period, and continue to have difficulty sleeping. So the idea is that the physiology is abnormal and there's hyperarousal. So our sleep-wake cycles are mediated by two different systems. One brain system keeps us alert, one brain system increases the drive for sleep. And it's been fairly clear that people who have difficulty with insomnia have physiological phenomena, abnormal hormone secretion, increased brain and whole body activation, elevated heart rates, sympathetic nervous system activation during sleep. So all this is signs of hyperarousal. And what's interesting is that this hyperarousal also occurs during the day. So you have both sleep and arousal systems that are both simultaneously active. So that's what's currently known about people who have chronic insomnia. So the hyperarousal leads to a state of continual arousal, both during the day and during sleep. And there's been significant and numerous research studies that have documented these changes. So the next question is, in terms of mental health issues, is that this hyperarousal looks a lot like depression or some aspects of depression. So there's been research that shows that both that people with insomnia and with depression have the same overactivation of the HPA axis, and they both exhibit too much cortisol. So there is an overlap between the physiological basis for insomnia and the physiological basis for depression. So that confirms the epidemiological findings that people with insomnia are very likely to develop depression. And so at least in 2007, they were talking about the idea of insomnia and depression as having a common risk factor or a common biology. So I'm going to switch now to the idea of primary care management of insomnia. And just this is a very nice article at the bottom for primary care docs. It's the most recent one I could find, but it's available free if you go to that website and you plug into that the web address on the bottom. So if you're interested in more the idea, in general identification and treatment of the sleep disorders, I would suggest taking a look at that. In general, you want to do a sleep history, try and screen out psychiatric and medical problems, look at substance use and medication use. There's many medications that can contribute to sleep problems. And you have to be on the lookout for restless leg syndrome, people that have shift work disorders, or obstructive sleep apnea. You need to weed those out before you're going to do anything. But referral to a sleep specialist really isn't necessary unless you have someone with very refractory sleep problems. So the recommended first-line treatment for chronic insomnia is not medication. And this has been true since the turn of the century. And multiple professional sleep disorder professional associations recommend that cognitive behavioral therapy that's specifically designed for sleep to be the first-line treatment for chronic insomnia. More than 5 years ago, the American Association of Sleep Medicine also recommended that CBT be the primary treatment, and that medication only be used for people that are unable to participate in CBT or still have symptoms despite having done CBT. And this is a more recent review, so just focus your attention in the bottom, and that's the multi-component cognitive behavioral therapy. Very strong evidence that is, and then I'm going to review this, but clinicians are not recommended to use sleep hygiene as a treatment for chronic insomnia, and we'll get into that. The reason is that sleep hygiene is great general advice, kind of like don't run with scissors, but it's not therapeutic, and so it's important to understand that. So the evidence base is pretty robust for CBTI. 87 randomized trials, and it has significant effects on multiple aspects of sleep, sleep efficiency, sleep quality, waking up at night, onset, how long a person takes to go to sleep, number of awakenings, all these physiological aspects of sleep improve with CBTI. And it's the authors in this 2018 meta-analysis deemed the results to be robust. And another review a little later found that it had moderate to large effects. They're believed to be sustained long term. And that's very important. So it's not like a treatment that needs to be done on a regular basis. Once you complete the course, it seems to have a lasting effect. The other piece of this is that there's been development, and I'm going to review these, and this is available in the appendix, that there's a number of digital forms of CBT that have been found to be just as effective as in-person CBT for addressing insomnia and other sleep problems. So I have a list of those programs. Some of them are, you have to pay for them, but some of them are free. So they're relatively widely available. One other thing is to not forget is, especially in people who are older, is exercise is a significant treatment for sleep problems. This is a meta-analysis that shows that almost every type of exercise, aerobic, strength training, improves sleep. And but it's mostly the subjective sleep quality, so people feel better about it, but they don't have all of the physiological measures that I reviewed for CBTI. But probably the first thing to do if an older person especially has problems or reports subjective problems with sleep but haven't hit the threshold of chronic insomnia. So, and again, and this is good news, it's vigorous exercises doesn't have as good effect as moderate. So just walking, gardening, doing that type of exercise seems to have the most beneficial effects on insomnia. Sleep hygiene is a good idea. It appears as though almost everybody on the call has some understanding of sleep hygiene because they've done things to improve their sleep, like turning off screens, doing some sort of stress management, other aspects of sleep hygiene are managing the noise and light in your bedroom. All these are relatively good advice, but they don't work as a treatment. So and I include the specific sleep hygiene habits in the appendix, but there's actually no epidemiological or experimental research that shows that people who do these things actually improve their sleep. So they're great, and I I think that they're good to follow in general, but if you have a sleep problem, they're probably not going to be very helpful. So I'm now going to transition into what I think is really, at least to me, was incredible news when I reviewed this literature. So, and this study that I'm focusing on is in older adults, but there's also other studies that have looked at just adult populations, middle-aged and younger adults, and have similar results. So, and it's also exciting to me that in my career, which is relatively long, if you see my white hair here, we've been looking for, good preventive treatments, and here's something that I think can be, the first really robust evidence-based preventive treatment in mental health. So the experiment here took a look at whether treating people with insomnia disorder, that's the chronic insomnia that I talked about. The diagnostic criteria are also included in the appendix if you want to look at specifically. But they looked at whether treating people with CBTI versus a comparator condition, an active control, sleep education, actually prevented the incidence, that's the development of new major depressive disorders in older adults. This was a community-based sample and enrolled about 431 people. Oops, daisy. Sorry. There we go. And they didn't have major depression to start with, and they had no major health events. They were followed up at 36 months, which was 3 years, and they were randomized to either the active treatment or the sleep education. And this study again replicated the CBT results that I talked about in previous slides, that people who were treated with CBTI had continuous sustained relief from their insomnia. So that was the first finding. And then, and this is pretty whopping, there was an 80% decreased likelihood of depression developing in those 3 years after their treatment than those who without the sustained remission of insomnia. So the people that were successfully treated had much less new episodes of depression. And I'm amazed that we haven't seen a lot of this. I think there's a lot of interest in this and a lot of development of prevention programs for depression in older adults. But this study is not alone, and there were other studies that I haven't included.
Dr. Westphal, I have a question. What does CBTI treatment look like? How do you go about the CBTI?
I'll do that when I get to the end. I'll go to the appendix and I'll go through and I'll talk about that.
Okay, great. Thank
you. That's a great question, and I'll take a look at that. So so sleep health is very important. It promotes physical and mental well-being, and sleep quality assessments are an important early indicator. I'm putting this in here because the previous study is fairly clear that if you address sleep problems, that you're likely to decrease or prevent future episodes of mental illness, especially depression. So I've also included, and I'll go through that, very brief scale, one-page scale of looking at people's sleep quality. So great question. I'm going to go to that. So here's the diagnostic. This is the appendix. Here's the diagnostic criteria for insomnia. It's got to occur at least 3 nights a week and be present for at least 3 months. So that's a chronic condition there. And then you have to have an adequate opportunity. And if you're, on call all the time, you don't have an adequate opportunity if you have sleep problems. But here's the sleep hygiene. Oh, sorry. Okay, sorry, don't have it here. I will do the. So I'll talk about the sleep hygiene, and I'll include a couple of slides. I'll send them to you. Later. So okay, so I'll send you. There are, what does CBTI look like? It's usually, if you do it in person, and unfortunately there's no practitioners that I'm aware of that do CBTI in the state, but if you do it in person, it's usually between 8 to 10 to 12 sessions, and there's a number of different topics, different things that are focused on. There's an educational component, but there's also a component to it that it's called sleep restriction. If a person is having difficulty sleeping, the advice is to get out of bed and do something else. So they use the principle of sleep restriction, and then when person feels sleepy, they can come back to bed. There are a number. So CBTI, or CBT in general, has been shown to work well with depression and anxiety. So what the person thinks about their sleep, and especially thinks about having a bad night's sleep, is very important, and it is very likely to continue the hyperarousal. So the therapy focuses on especially how a person thinks about their sleep, and gets them to stop catastrophizing. The idea is to stop making it a horrible thing, and adjusting their thoughts about sleep to a more appropriate level. And there's a thinking component to the hyperarousal, and the CBTI focuses on that. So there's a number of behavioral pieces like sleep restriction, but there's also a number of or a focus on how the person is thinking about their sleep, and what they can, and to calm that down, and then to calm down the hyperarousal. And the hyperarousal is usually not only occurring at night. So the typical scenario is the person goes to sleep or tries to fall asleep, and they're having rumination, meaning that they're thinking about stuff about their day, and they're thinking about stuff that they did wrong, and they're thinking about stuff. And the CBT focuses on techniques to reduce that rumination, and that tends to reduce the hyperarousal. I have a slide that I will include when in the email, that there's about 8 different programs that are available, some for free, some uh, uh, for pay. But there's especially one program developed by the Veterans Administration, used for helping vets with problem sleeping. It's very good, very well done, and it's free. And I'll send the slide on that. And I also have a slide which identifies there's about 7 or 8 different components to CBTI. And so it's done as a module, and you complete the component and then go on. So that's a rough description of CBTI. So I just want to finish. So sleep is a public health concern that intensified with COVID, especially, and this is like a worldwide phenomenon. Insomnia is prevalent among adults and usually is chronic. It has multiple physical and mental health consequences. It is especially, the recent research has shown that it's especially important for the new onset or incidence of depression. So anybody who has chronic insomnia, that is a significant risk. CBTI is a first-line treatment, and the digital forms are as effective as standalone treatment or as treatment in person. There are at least 3 randomized controlled studies now that show that CBTI with successful resolution of insomnia drastically reduces the chance that a person will develop depression, at least within a 3-year time span. Pharmacological interventions for insomnia are evidence supported for less than 16 weeks. So all of the evidence, all the medications that are advertised and pushed for insomnia, the evidence base is less than 4 months. So we really don't know the long-term effects. The pharmacological use, there's minimal harm data available for longer use than, say, 3 months. And there's no evidence, and probably highly likely that the pharmacological treatment of insomnia keeps the basic physiology of hyperarousal, or doesn't treat that, and that underlying physiological condition continues. So then that's the reason for all the sleep societies' recommendations for doing CBTI versus using medication. And then sleep hygiene, although great ideas, has no evidence base. It seems to be pervasive in our culture, but there's no evidence base. And if a person really has problems with insomnia, we should look elsewhere. It's probably good for people with subjective complaints or sleep quality issues. Probably has a placebo effect. So questions, thoughts, comments?
We have a question there in the chat.
Okay, let me see if I can get it.
So mindful movement such as
okay.
Qigong.
Okay, so yeah, EFT also has techniques for treating insomnia, and yes, the anticipation or the worry or anxiety about not being able to sleep tends to be the most uh, significant aspect. And I will, as I said, I'll find the slides on the specific programs and the web addresses, and I will do the. I have a couple of slides on what the actual components are. Let's see, other questions. There we go. So our Qigong, so yeah, so almost anything that will reduce hyperarousal will be helpful. So like prayer, meditation, movement types therapies. And I've seen a lot of articles on the internet about sleep problems and people doing a couple of yoga poses, that sort of thing. All of that can be very helpful. And if you're in the range of you want to improve your sleep quality or you're a little unhappy with your sleep, all those things can be useful. If you get to the point where you have a chronic insomnia, meaning that you're having difficulty sleeping at least 3 times a week for at least 3 months straight, you probably need to go to something that has a little more evidence backing for the like CBTI. So great. CBTI is all over YouTube. Great. I don't know if they have the full sessions, but I'm going to send you guys the evidence-based programs that I've found, and so I think it's very important to use something that follows that has treatment fidelity rather than says it's CBTI, and CBT of anybody who's actually participated or seen it is a very participatory. It's not that you watch a video on YouTube. There's homework, there's things that you do, you keep track of things, there's diaries. So it's very important if you're going to recommend this to someone that they do something that has treatment fidelity. So I did the what does it look like? Any other questions or comments?
Anybody have a case to present or any other questions for Dr. Westphal? Thank you, Dr. Westphal.
Okay, appreciate it. I'll send you the information.
Yeah.
I'll do that this afternoon. Okay.
Yeah, and send me that, and then guys, we can get it posted up on our website. Any other last chance for Dr. Westphal? Questions? Some mahalos? No, but definitely didn't put Ella to sleep.
Okay. All right. Thank you very much.